I don't know, I'm going to get all the information as much as possible, I will say. So first is, we're going to talk about anemia. You know there are different ways to classify anemia. You can actually, one very good classification is based on mechanism, underlying mechanism. And that way you can actually divide it very much in two types, or sometimes three types. I will mention that, two types. Anemia underproduction, so there is something wrong with the bone marrow, doesn't produce red blood cells or any other component, so you get anemia. Or anemia with increased destruction, and you know that's as a hemolytic anemia, and we're going to talk about that in next case. This case, actually, first case, talk about the anemia underproduction. So when you think about underproduction, think about maybe something wrong with the whole bone marrow, stem cells. For example, if there is a stem cells immunologically damaged, which we call it aplastic anemia. So it's very important point about aplastic anemia. Most of the time, the cause is some kind of immune-mediated damage to stem cells. And it's not just an anemia, it's pancytopenia. We're going to talk about that. Sometimes it can be a red cell aplasia, which is really, anemia. We'll talk about it. Sometimes there is an infection producing lots of cytokine and suppress bone marrow, and you get the underproduction anemia. This is anemia of chronic disease. So usually it's due to the cytokine that actually suppress marrow. Additional things that you're going to see in the anemia of chronic disease, also they affect the iron metabolism. So you have this sequestration of the iron there too. Now, that's not really cause of anemia in this anemia of chronic disease. Okay, so that's the secondary change. The cause of anemia of chronic disease is a direct suppression of those marrow with cytokine. But we're going to talk about that effect on metabolism of iron because they love to ask you, because it's always can be mistaken with iron deficiency anemia. Sometimes you have an anemia underproduction of component of the, for example, red blood cells. Imagine there is a problem with the production of hemoglobin. Hemoglobin composed of heme and globin. So if you have an underproduction of globin, you can have an underproduction anemia, and that usually happens in thalassemia. We're going to talk about that. Mainly we're putting minor thalassemia in the underproduction. The major one actually is also hemolytic anemia. We'll talk about that. Imagine there is an underproduction of the heme. So one of the common cause, nutritional causes, is iron deficiency anemia. So again, it's anemia underproduction. What is interesting is when you have underproduction of the hemoglobin or cytoplasmic component of the RBC, usually you have this cytoplasmic maturation defect. So what's happened is the cells usually are small, and since you don't produce hemoglobin, they're hypochromatic. So every time there is an issue with the production of heme or globin, you're going to have a hypochromic anemia, which we call a cytoplasmic maturation defect. That makes sense. We will look at the picture that shows how they mature. Now let's go to the nucleus. If there is, for some reason, problem with the nuclear maturation or DNA synthesis, again, is some form of underproduction. And that's usually what you see associated B12 or folic acid deficiency, which are actually, when you have that, what we call it maturation defect in nucleus. Normally, when we look at these cells when they get mature, nucleus becomes small, and disappear. And then you have cytoplasm actually all become hemoglobin. So if you don't have a nucleus that easily disappear or maturation, there is some defect or delay, the cells are larger. That's the reason every time you have a DNA maturation defect, you see the cells are macrocytic or megaloblastic. As a matter of fact, every time the DNA maturation defect, you see megaloblastic. Macrocytic usually is not the DNA problem with DNA synthesis. Okay. So that's pretty much overall what we're going to talk about these cases, underproduction. And we already mentioned the most important one. Now, sometimes instead of going with the underlying disease, you can actually talk about the based on the morphology. So some people say this is a microcytic hypochromanemia, some people say megaloblastic. They want to every time they ask you, they usually give these indices, MCV, MCHC, and based on that, you should have a differential diagnosis. So you can actually look at the data. So if you have a microcytic hyperchrominemia, I already talked about it. What are the causes? Iron deficiency anemia. We said thalassemia minor is another one. Now there is two other talk about the anemia of chronic disease. Usually, or 80% normal chromocytic, but 20% can be a mild hyperchromicity. Also, with lead toxicity and sideroblastic anemia, you get these hyperchromicrocytic anemia. And the reason for that is the same concept. They actually interfere with the production of the heme. So it's the same way, actually, they affect the same cytoplasmic maturation defect. Now, so this is our case. So every time we talk about iron deficiency anemia, it's nutritional. Depends on the age. There are causes. For example, in infants, this is usually milk doesn't have enough. For example, iron. So if you don't start introduce solid food delay, they can get. But one of the very important cause of iron deficiency anemia is chronic loss of blood. And with that, chronic loss of iron. For example, through the GI tract, through the pulmonary, or in the urine. The most important one is the GI tract because it's the one that is loss of time. They don't notice, they don't see anything. If there's a hematuria in the urine, you see it right away, they go to the doctor. So, or even if there's a hemoptysis, it can be seen and it's something that they go, to the clinician. So that's a very important cause. Also, there is another cause of the chronic loss of iron is through the chronic intravascular hemolysis. So that's important. If somebody has a chronic intravascular hemolysis, we're going to talk about that in the next case, and it's chronic, they can lose a lot of hemoglobinuria, and they can lose a lot of iron. So they can actually develop iron deficiency anemia. Okay? So we already know differential diagnosis. So the way we make a diagnosis, we do these. We can do these, indices, and we can do iron study. You all know that serum iron is going to be low. Total iron binding capacity is going to be high. Remember, iron binding capacity is telling you how much space available on that binding protein. So if you don't have any iron, there are more space available. So your TIBC is going to be higher. You can, when you look at the ferritin, that actually telling you the iron stores in the marrow, that's usually low. That's the first thing goes down in the iron deficiency anemia. You notice that MCHC is low, MCV is low. One thing actually for iron deficiency is helpful. Usually, from all those 3-4 differential diagnoses I mentioned, iron deficiency is the one associated with more severe MCHC decrease. So that's important. Another feature that is relatively a characteristic of iron deficiency is something we call it anisopoikilocytosis, and the lab test that's showing that is RDW. So when I show you this, RDW is a red cell distribution width, and when I show you this picture of normal and you see iron deficiency anemia, which is a hyperchromicrocytic anemia here. So when you look at these cells, first of all, you see lots of spaces between cells. That's, you can say this is probably representing anemia, but otherwise you make a diagnosis of anemia, you have to look at hematocrit hemoglobin. And that's representing red blood cell mass. It's not always, hematocrit is the one that's not always correlated because if the patient has dehydration or fluid accumulation, those are not going to be very precise. But when you look at those two and they're low, is anemia. And then when you look at here, normally should be a 1/3. Central polarity is more, so it's any hypochrome, less hemoglobin. So that's the reason MCHC was low, and they are small. Now I don't have anything to compare, so you may ask me, how do you know they are small? I usually compare with the lymphocyte, but compared to previous picture, they're smaller. So it's a microcytic hypochrome, all those differential diagnoses there. Well, one thing about iron deficiency anemia is very helpful, but you see they are very much different size. And that you don't see that with, for example, minor thalassemia. I mean, you see stuff with thalassemia minor, we'll talk about it, or others. So the red cell distribution B, RDW usually higher iron deficiency anemia. And actually, when you treat that responds very well. So it's coming back to the normal. So that's what iron deficiency anemia. This patient was a chronic blood loss, and then every time you hear iron deficiency anemia, like this presentation, anemia, and then this, think about the possibility of the, GI tract tumor or something like that. Endoscopy is the first thing you want to do. And here they're telling you what's happening. This is a normal, and you can see this is the iron stores here. These are macrophage, like the macrophage we call it. And normally transferring come and take these and take it to the normoblast, okay? And then normoblasts start, maturation and then become RBC and first reticulocyte, then release, and then RBC. So I want you appreciate here, these are some of the actually nucleated red blood cells or normoblasts with some, some area that shows the iron. And these are sideroblasts, so you can see some sideroblasts if you start seeing a lot of them, and the abnormal actually configuration of iron, that's going to be a sideroblastic anemia, so we're not going to talk about that. But that picture showing this is our case, no iron. So that's the reason your ferritin was very low, so no iron store. Remember, ferritin is an active phase reactant, so it's not very precise. Sometimes actually it can be falsely high, but when you look at bone marrow or something like that, no problem. There's no iron here. Okay. Now, so done with the iron deficiency anemia. Another things you saw the test actually we did. Serum ferritin transferrin saturation is a very reliable test to evaluate iron. So I will say the fact that some of these others can actually, especially ferritin, can be actually up and down because it's actually phase reactant. I very much suggest using these transfer saturation. Later when we talk about the also anemia of chronic disease, you will see that's very helpful. And that's actually the ratio of the serum iron to the TIBC. So you can see serum iron is low here, so that makes sense. So, and normally it should be a 20%, so less than a 20% blood transfer saturation. You have to think about the iron deficiency anemia. And actually helpful for the hemochromatosis. So usually if it's an increased iron deposition, that's going to be more than 50%. Now, let's go to the next picture. Now we talk about the iron deficiency and microcystic hyperchrome. Let's talk about the megaloblastic. We already talked, every time I say megaloblastic, is there something wrong with the DNA synthesis? Now you may hear something like macrocytosis. Macrocytosis, just the contrast of microcytosis, is larger red blood cells, and you see some of them here. These are larger ones, okay? And there are some smaller ones, some normal ones here too. So this is a very much shows the anisophytocytosis, but you can see there's some larger ones. So macrocytosis can be due to them many things. Liver disease, hypothyroidism, can be due to, if you have a reticulocytosis, you're gonna get the MCV high because reticulocyte is a little bit larger than just normal RBC. We will talk about reticulocyte in the next case. But then I said megaloblastic. It's a DNA synthesis problem, and usually are larger. Macrocytic never MCV goes more than 110. When you see actually megaloblastic, they're much larger, and there you see other problem associated with DNA synthesis, and we'll talk about that. So there are abnormal form that helpful for you to say this is a megaloblastic. You already know the role of B12 and folic acid. B12 actually activates folic acid, and folic acid is needed for the DUNP to DTMP and then DNA synthesis. Now, another important point when you compare so at the level of the peripheral blood and bone marrow, if you have a B12 deficiency or folic deficiency, the picture is similar, completely similar. And what is interesting, actually, somebody have a B12 deficiency or folic deficiency, if you give them an acid folic, cover both of them. I'm talking about that, the level of bone marrow and problem related to anemia. But the problem with the B12, there are other actually, issues you get with B12 deficiency that you don't get that with folic acid. Because B12 is important. There are another processes involved. You know about methylmalonyl-CoA to the succinyl, and then if you don't have a B12, there's going to be accumulation of the methylmalonic acid.